Welcome to the second part of our lecture on Chapter 4. So, in this part, we're going to talk more about the nuts and bolts of how, especially psychoactive medications, interact with neurotransmitter systems. I alluded to this a little bit earlier when I was talking about antagonists and agonists and almost went into the nuts and bolts, but kind of held back. Here we're going to go into more of the nuts and bolts and how this actually works and how these different forces interact and have an effect. So now that we've gone over the major systems of neurotransmitters, we turn our attention to the psychoactive medications, as most of them have effects on the brain throughout either interacting with neurotransmitters or with interacting directly with the neurotransmitter receptors. As we mentioned previously, different receptors appear to be associated with different purposes or diseases. For this reason, medications are often made to target one receptor when possible. When this targeting is not possible, you can see a medication that has side effects. So, for instance, if you block more than just the one type of receptor, even if you block the one, anytime you have a medication, if it works, it's going to have a side effect. So all medications have side effects of some sort. But the more you block that you don't mean to, we call those dirty drugs. They're going to have much more side effects than you would otherwise. So the more you have it where they're blocking or affecting other receptor types, the more of a chance you have of significant side effects. So, for instance, SSRIs. SSRIs are actually fairly selective, as the name would suggest. But even they have side effects. They have sexual side effects, namely decreased libido. And this makes some sense. As you'll likely remember, serotonin is hypothesized to be responsible in part for sex drive. So while medications can be helpful in one way, they can also lead to problems. So knowing the neurotransmitter systems that are being affected can actually also be helpful for understanding and predicting side effects. There are a few terms that we should discuss in reference to medications. First is binding affinity. This is sometimes just called affinity. It's the propensity of molecules of a drug to bind to a receptor. Thus, a drug with high affinity for D2 receptors, D2 dopamine receptors, would be very likely to bind to those receptors, whereas one with low affinity would be much less likely to bind. Efficacy is the extent to which a drug activates a response when it binds to a receptor. So, if the drug causes a strong response, it would be said to have a high efficacy. However, a drug with low efficacy may have little or no effect even when it does bind to a receptor. So both of these are very important when looking at medications. You could have a drug that for instance, has great efficacy. If it binds, it has a major effect, but may have very low binding affinity. So it takes a lot of that medication in order to have an effect. And this is why different medications require different amounts. It's why you don't just give 100 milligrams of everything, because you have differences in the efficacy and in the binding affinity that lead to differential effects of these medications. So this is where it gets a bit tricky. So we're going to take some time on this slide and just let me know in class if this doesn't make sense. So partial agonists and antagonists. So these are drugs that, when bound to a receptor, have less of an effect than the endogenous ligand would. So let's say, just hypothetically, you have a medication that binds to serotonin receptors, but has a lower efficacy than serotonin. So it doesn't have as large of an effect to serotonin. So what you have then is, even though it's doing the same thing serotonin would, it's blocking that receptor and producing less of an effect. So it's actually causing a slightly antagonistic effect because the serotonin can't bind there. So with that, when you have a ligand, a exogenous ligand that's less effective than the endogenous receptor, um, for instance, well, first, what we call those are either partial agonists or antagonists. So they have a medium response regardless of the dose. They're not as effective as the endogenous ligand. And then with that, they can actually have the opposite effect. So again with that serotonin example, if you have a partial agonist that binds to a receptor, it can actually have an antagonistic effect. Because it's going to reduce the effect of serotonin because it's blocking that receptor and not having as strong of an effect. So partial agonists and antagonists are important because while they are operating in the same way as the neurotransmitter, they don't actually help. They actually reduce the effectiveness of that neurotransmitter. There are also competitive ligands, and these are drugs that directly compete with the endogenous ligands for the same binding site on the receptor molecule. So with that, you may have a drug that, actually a lot of drugs work this way, where they'll bind to a receptor site, but they won't actually activate anything. So with that, that would be an antagonistic effect because it's binding to the site, it's not doing anything, and that would reduce the effect. But so going back to competitive ligand, it's not always antagonistic, but all a competitive ligand means is that the drug and the receptor and the neurotransmitter use the same receptor. That's all it means. You can also have non-competitive ligands. These bind to a modulatory site on the receptor instead of the main receptor site. So here it's non-competitive because the drugs that affect the neurotransmitter bind at a different site than the endogenous ligand and thus do not compete with it. So going back to that where I told you that a partial agonist can act as an antagonist, that is only the case for a competitive ligand, where they're fighting over the same receptor. If it's a non-competitive ligand where they bind to different sites, then it doesn't matter. Because they're binding to different sites anyway, both are going to be effective. So make sure you read and understand that section. If you have any questions, let me know, because it gets a little confusing how something can be an agonist and an antagonist at the same time. But it all comes down to how effective that agonist is, and is it blocking something that would be more effective. So now that we have that terminology down, let's start talking about psychodynamics. So psychodynamics are the factors that affect the relation between a drug and its target receptor, such as affinity and effectiveness. So one of the best ways to examine psychodynamics for a drug is what we call the dose-response curve. And you see it here, it's a formal plot of the drug's effects versus the dose given. The 50% line you see here is the dose at which 50% of people show a response. So that's the ED50. So that's the effective dose for 50% of people. So the relative potency of two drugs can actually be compared by their ED50. So a drug that has a comparable effect at a lower dose, so here we have our dose, here we have our response. So something that's an ED50 here, for instance, would be viewed as more potent than a drug that has an ED50 here. So that's dose response curve. So again, it's how we look at the relation between dose and effect. And it's a very important part of the next graph, which is therapeutic index. So the dose response curve is often paired with the lethal dose curve to determine the therapeutic index. The LD50, which is shown here, is the dose. Here, let me point it out. LD50 right here. This is the dose at which 50% of participants die. So we don't want to get too close to this mark. So like with the therapeutic index, which means that, or let me take a step back. So what what this means is we can look at the difference between where a drug is effective and where it's lethal. So if this is a wide range, we say this is a wide therapeutic index. This is what we want to see. We want to see a drug that, maybe is effective at 50 milligrams, and you'd have to take 2,000 before it would actually harm you. That would be a really good, situation. Because of this, drugs with a wide therapeutic index are always preferable, almost always preferable, to those with a lower therapeutic index. However, sometimes we have no choice but to use a drug with a lower therapeutic index because it may have a certain effect that we can't get from another drug, or there may be other factors that are involved. A good example of this is lithium. Lithium we use for bipolar still. We've used it for a long time. And it has a low therapeutic index. So the effective dose and the lethal dose is not very far apart. We use it because it's still as effective as anything out there, and it's a lot more affordable than a lot of the other medications. But with it, as some of you may know, if you know of anyone who's been on lithium, you have to do blood checks. We have to check your blood levels frequently to make sure that you're not actually at a dangerous level of lithium. So that's the downside to having a narrow therapeutic index, is you have to be very careful to make sure that the dose is in the range where it's effective, but not too close to the range where it may be lethal. Drug tolerance. A couple different ways that drug tolerance can happen. So first of all, drug tolerance is after you have a drug successfully, so you take a drug for a while, it becomes less and less effective. So why does this happen? Well, it can actually happen in a couple ways. One is metabolic tolerance. So this is that the organ systems just become more effective at eliminating the drug from the body. And this is actually very important in relation to drug overdose. So this is one of those things I'm going to do a soapbox for 2 minutes, but if you get very little of this class, this is one of the things I hope you take. One thing you may notice if you watch where people overdose, if you look at the reports of when a celebrity overdoses and dies, it's almost always someplace other than their house. It's usually at a hotel room or on the road. Very rarely is it at home. And the reason why is that there are cues in the environment that start the metabolic tolerance going. So with that, so if you use a drug in the same place every time, some of those cues of going to that place, doing your preparations, whatever it is, actually the body, when you're doing that, it cues the process to counteract the drugs to start. Now, what happens when you do the drugs in a new environment? Well, the body doesn't have that head start. So because of that, you can have it where a dose that is not lethal in your normal, usual environment is lethal in a place that's new, because the body didn't get that head start with the organ systems to eliminate the drug. So often what happens with overdoses is that it's not that they took more of the drug than they normally do, but they did it in a novel way, or they did it in a novel place, and it eliminated some of this conditioning that had previously occurred. So the drug had a stronger effect than normal because the body wasn't counteracting it as much as normal. So I throw that out there just because it's important to know about. It's a life or death issue, so I feel like it's important to mention. So that's metabolic. People want to say metabotropic, but that's different. Metabolic tolerance. You also have functional tolerance. So with functional tolerance, it has to do with up and down regulation of receptors. So you can actually have the brain in response to drugs can actually either increase or decrease the number of receptor sites that are there for that drug. So if you're overloading the brain with dopamine, for instance, what the brain will often do is downregulate the number of dopamine receptors, and this happens rather quickly. So with that, you can actually have the drug become less effective because there are less receptors for it to bind to. So those are the two main ways that drug tolerance develops. You have the metabolic, where the body starts counteracting the drug even before it enters the system, and gears up the mechanisms that are needed to eliminate the drug. And you also have that functional tolerance, where you may just have less receptors than you used to for that drug, and that's why it doesn't take, because it doesn't bind. So again, this is actually just going back to what I was mentioning. You can have changes in the number of receptors, and that changes the sensitivity. Downregulation is where it's in response to an agonist drug, so a drug that's increasing the effectiveness of a neurotransmitter system, and it will downregulate, meaning take receptors away to counteract that. And you can also have it upregulate in relation to an antagonist. So if you're blocking dopamine receptors, you can actually see more dopamine receptors pop up to try to get back to more of that equilibrium, or more of that homeostasis where it used to be. Cross-tolerance is similar to tolerance, but what this is where you have tolerance to a class of chemically similar drugs. So it's where you see, say, different types of pain medication. If you have tolerance for one, you may show tolerance for another type of pain medication because they're chemically similar enough that the same mechanisms either clear them out, or it's the same receptors that they're binding to. You also can, of course, have withdrawal symptoms. Some of these may be caused by drug tolerance, for sure. But with withdrawal symptoms, they're usually the opposite effect of the drug. So, and this kind of made sense when you think of these receptor systems. So if you're, throwing a bunch of, let's just use an example. So let's say you were having a medication that was increasing dopamine levels. So in relation to that, dopamine downregulates. So you have fewer receptors. After that happens, then you have less effective dopamine in the brain than you had before you took the drug. So whatever effects you had by increasing dopamine, you would probably have the opposite by decreasing, and that's what happens with withdrawal symptoms, is you have the opposite. And that's why also people will often, as we'll talk about in later lectures, take more of the medication to kind of get rid of that withdrawal symptom, because they just need to get up above that level again. You also can have sensitization. This is where a drug's effects actually become stronger with repeated treatment over time. So a drug's effects generally depend on how the drug is administered, as the amount and the speed that the drug takes to reach the brain varies by how it's administered. So this is accounted for by the concept of bioavailability. So drugs that are injected or inhaled typically take action quicker than those that are ingested because they reach the bloodstream faster, and thus they're bioavailable much faster. Injected drugs also require much smaller doses because more of the dose makes it to the brain than drugs that are ingested by mouth, so that are swallowed, for instance. So the duration of a drug's action is also largely determined by how it's metabolized. A drug that is metabolized quickly will be effective for a much shorter period of time. The reason I say that faster metabolism often, but not always, leads to shorter duration of action is because sometimes the metabolite is also psychoactive, which means when you break up whatever the drug is, the things you break it up into are sometimes also psychoactive. They're also having an effect on the brain, and this extends the effect of the substance and sometimes also results in different side effects. There's also biotransformation, which is a process in which the enzymes convert a drug to a metabolite that itself is active, sometimes in ways that's different than the initial substance. The metabolite is usually weaker than the main drug, but this isn't always the case. For instance, actually encoding the metabolite is actually stronger than the main drug, so you get most of the effect from that metabolite, which I think is really interesting. Pharmacokinetics, we'll talk a lot about this, but this is just all the factors that affect the movement of a drug throughout the body. So, we just talked about availability, the method of ingestion, how fast it's metabolized. All these are part of the pharmacokinetics and affect the way the medication or the drug affects the body. The blood-brain barrier is also a very important aspect when it comes to psychoactive medications. So the blood-brain barrier are very tight junctions within the central nervous system that prevent the movement of large molecules into the brain. And because of this, it can limit the drug's availability. So there are a lot of medications that are actually too big to make it into the brain. And with this, that's why, as I mentioned with dopamine, we can't just give someone dopamine. It doesn't work. It can't go through that blood-brain barrier. So with that, we have to give something, a metabolite, or we have to give one of the precursors, something that can cross the blood-brain barrier in order to have the effect that we're hoping to have. So it makes it so we have to be a little more creative in how we make these medications. It's also important to mention that a drug doesn't even have to make it into the brain to have an impact on the nervous system. So, for instance, local anesthetics such as Novocaine block the sodium channels at the site, and therefore they block action potentials. However, most psychoactive drugs alter synaptic function in some way. So, even if it's not having an effect on the brain, if it's psychoactive in any way, it's probably altering synaptic functioning. Some chemicals are not neurotransmitters themselves, but they affect the release of neurotransmitters. These chemicals are called neuromodulators. Neuromodulators are substances that affect either the release of neurotransmitters or how the receptors respond to them. So caffeine is an exogenous neuromodulator that blocks the effect of adenosine, which is an endogenous neuromodulator that normally inhibits catecholamine release. So SSRIs and MAOIs are also examples of neuromodulators where they affect the release or they affect the reuptake, but they're not directly binding to the site to have the effect. They have the effect through instead affecting the neurotransmitters themselves.